My name is Dr. Sabitu Muhammad Zainu. I am consultant microbiology with Usman Danfodio University Teaching Hospital. I am the head of Infection Prevention Control and Anti-Microbial Stewardship program of the hospital. I am providing technical assistance to Nigerian Center for Disease Control in relation to antimicrobial stewardship as well as infection prevention and control. I am also providing diagnostic stewardship to Maitama District Hospital. Our topic of discussion today is the linkage between antimicrobial stewardship, antimicrobial resistance surveillance, diagnostic stewardship, and infection prevention and control. We'll go by following these outlines: antimicrobial resistance and antimicrobial misuse, antimicrobial resistance surveillance, priority specimen and pathogens in Nigeria, diagnostic stewardship, and mind-me criteria, which is a criteria of directed use of antibiotics in the hospital, antibiogram and uses, as well as I will discuss some aspects of infection prevention and control. Then I will summarize the key factors of infection and prevention and control and antimicrobial resistance. By way of definition of antimicrobial resistance as well as antimicrobial misuse. So what brings antimicrobial misuse? The essence is responsible use of antibiotics. So antimicrobial resistance is a resistance of microorganisms, bacteria, fungi, viruses, and some parasites to antimicrobial medicine to which it was originally sensitive, meaning that you are using an antibiotics for so specific organisms now. Later on, you found out that even if you give this antibiotics, the organism is not sensitive to it, and you cannot treat such infection caused by that microorganism. So actually, it is a natural biological unstoppable phenomenon which is driven by rampant misuse of antimicrobial agent. And that's why now the target is responsible use of antibiotics. And data has shown that 50% of antibiotics that are prescribed are inappropriate in our hospital. And 50% of patients have poor compliance. For example, now you will prescribe antibiotics for a patient to take for 5 days. A patient will start taking that antibiotics for just 1 day or 2 days. When he starts feeling better, he stops. This is irresponsible usage of antibiotics. And 50% of the population do not have access to essential antibiotics. There are some common essential antibiotics that are on the World Health Organization access list, which is supposed to be easily accessible when a doctor prescribes. Antibiotic is a prescription-only medication, so it can only be purchased when it is prescribed. So this the essential medicine or the essential antibiotic should be readily available once prescribed. So we have a governance structure relating to how the antibiotics is used in Nigeria, or the guidelines. The target is what we call One Health. One Health means you incorporate animal health issue, environment, and human health to stop the spread of resistance of antibiotics. In a situation whereby maybe one aspect is responsibly using antibiotics, for example, now let's say the animal health are responsibly using antibiotics, but the human health are not responsibly using antibiotics. So this is a problem. As well as if we have issue with environment, there are so many problems whereby so many antibiotics are being exposed to environment as a waste. So it also leads to some aspect of antibiotic resistance. And an issue on One Health, we know that there are so many animal farms or farms industry that are using antibiotics to improve production. This also really lead to so many issues related to antibiotic resistance. The antimicrobial surveillance means tracking of changes in microbial population for early detection of resistant strain of public health importance, reporting of trends in resistance on a periodic basis. Whereby, so surveillance, we all know what surveillance is. You are watching, you are actively looking for something that can cause trouble. So when you identify these problems, you take measures. So active surveillance is what we are doing in relation to antimicrobial resistance. So the findings are quite important. When we found that this organism is resistant, so it informed clinical therapy decision. So if an organism is resistant to an antibiotic that the patient is on, and you are actively looking for it, and you found that, it directs the next antibiotic to be used for treatment of such cases. It has an impact on resistant containment intervention. So the resistant pathogen now, you contain it, you stop it, you manage it so that it cannot lead to so many cases of mortality or untreatable cases in the hospital. It guides policy recommendation. If you have a resistant pathogen or a kind of antibiogram in your hospital, this is a kind of empiric use. It guides on how empirically you can use antibiotics in your hospital. The key elements for establishing an antimicrobial resistance stewardship system. So like in Nigeria, the concept in Nigeria, what we are using, we have a national coordinating center, which is NCDC, and it is NCDC that is providing this message so that everybody should be aware of antimicrobial resistance program or antimicrobial stewardship program. And that's set up a laboratory network for antimicrobial resistance surveillance. So we have national reference laboratory for antimicrobial resistance. We have at least one central surveillance science site laboratory, at least one for, let's say each state should have a one sentinel site whereby you look for resistance. And ideally, each hospital should have a system that is taking for resistance in the lab. And you select priority sample. There are some samples that are quite important, like let's say blood sample, bloodstream infections. So it's quite important to have a sample, priority sample like blood CSF, that you can look for priority pathogens. You have a laboratory quality management system. Laboratory quality management system, you need to have a result that of higher quality, that is representative of the patient, representative of the sample collected, and can be used for treatment of such cases. You also, because you have established this system, it helps you to have epidemiology and data management structures. So if you have data management structure, all this information you have, you know how to manage it, you know how to use it to improve services to the patient. So now, if we are now doing AMRS surveillance, that is antimicrobial resistance surveillance, so what are the priority specimen and pathogen in Nigeria? So we know we collect different samples. We collect blood, we collect stool, urine, even skin scraping, genital and urethral swab, and cerebrospinal fluid. So, for example, now, what are the priority pathogen for sepsis? Priority pathogen, if you collect blood sample now, you are suspecting that somebody has bloodstream infection. So we are targeting in Nigeria the following organisms: Escherichia coli, which is gram-negative organism, Klebsiella pneumoniae, Acinetobacter baumannii, Staphylococcus aureus, Streptococcus pneumoniae, and Salmonella species. These are our priority pathogen in Nigeria, and these are also priority pathogen globally. So that is for bloodstream infection. Any blood sample you collected, this pathogen, you see them, they are priority pathogens, and you look for them and you report them. And we also for stool, we keep having sporadic cases of the outbreak of cholera. So Vibrio cholerae as a pathogenic organism of cholera is a priority pathogen as far as stool sample is concerned. So anytime you have seen Vibrio cholerae as you isolate it from the stool sample, it's an alert to the system, and you have to report it, and because it requires immediate public measures to stop such spread of pathogen. So if we go to cerebrospinal meningitis, so if you collect CSF sample now and you see Neisseria meningitidis, so it's a priority pathogen in Nigeria, one has to report it for necessary action because it is a disease of public importance. So now, what is diagnostic stewardship? It simply implies appropriate use of microbiological diagnostic and lab testing to guide patient management and inform empiric treatment guidelines. So you provide a kind of mentorship or a kind of program whereby you diagnose infection, ideally in an ideal way, in a quality manner, and you use this finding you have so that you can treat your patient better in a standard way. And it also highlights the importance in supporting rational selection of targeted antibiotic treatment and informed IPC measures. So I mentioned earlier in my introduction, I say infection prevention and control is key to prevention of healthcare associated infection, as well as limiting the spread of antimicrobial resistance within the hospital. So when you link your laboratory and the infection prevention and control, this is how you prevent healthcare associated infection, as well as the measure you take to prevent the spread of such resistant organisms. So available data on infection, pathogen, resistance, and use of antibiotics at the hospital is necessary for antimicrobial stewardship. What we mean here is you have your current laboratory procedure anytime, and you identify so many organisms that are sensitive to some antibiotics. This is what you will use to direct empiric therapy for your patient in the hospital. Now, as I mentioned earlier, I will expatiate more on what is man-me criteria in relation to antimicrobial stewardship, as well as the diagnostic stewardship, as well as the resistant pattern. So what is M? You see, it's a mnemonic standing. M stands for microbiology guide therapy whenever possible. You should not blindly just be given antibiotics like that. You need to be guided by laboratory result, in the sense that laboratory is telling you that I isolated so organism and so antibiotic is sensitive to that organism. So you should guide the choice of antibiotic you use. Indication should be evidence-based. Commonly, you say in my environment, the common cause of bloodstream infection is E. coli, and the common pathogen antibiotic that is sensitive to this E. coli is, let's say, ciprofloxacin. So this is an evidence base. You have an evidence at hand that any infection you have, commonly, majority, let's say 90%, is caused by this organism. So you can direct your therapy to that organism based on evidence you have in the laboratory. Narrowest spectrum require. That's what we call watch classification of antibiotics. You start with some antibiotic that is narrowest spectrum, that is can cover that organism only, or let's say only 2 organisms, so that you can limit the irrational use of antibiotics as well as spread of resistance. You have to ensure that the dosage of appropriate to the site and type of infection. So the dose, some infection require higher dose because of the nature and site of infection, like infection of central nervous system. You have to consider the antibiotic that can cross blood-brain barrier. That's what it means, site of infection. And skin infection, you have to consider the antibiotic that can cross tissue. And you minimize the duration of therapy. You should not just give antibiotic openly. You say, patient, keep taking. No, as much as possible, is guided by minimum duration. If 3 days can treat infection, why not 3 days? It means single dose, like some infection related to sexually transmitted infection, gonorrhea. Single dose of therapy is also required. And you ensure monotherapy in most cases. It's evidence-based, laboratory-based. If one antibiotic is the best to treat infection, why combining 2? So the target is to ensure one monotherapy, one antibiotic to treat infection. Antimicrobial stewardship in the context of diagnosis pathway. So what we are discussing here, you focus on infection, not on patient. This is patient, has also infection, you focus on this type of infection, not you, because you want to please patient, you give him any form of antibiotic. But what type of infection? Is it respiratory infection? Is it bloodstream infection? Is it urinary tract infection? So, and when you focus on the infection, you know the representative sample you're supposed to take. Which sample will you take? You cannot take urine if you are suspecting bloodstream infection. So if you are suspecting urinary tract infection, you take urine. If you are suspecting bloodstream infection, you take adequate quantity of required blood you need. And it's a kind of teamwork. If you require another patient service, if you require laboratory team to come in and help you to take sample, you communicate with them so that they can come and take you. So clinical team, what I'm trying to say here is the pathway is a we have pre-analytical, analytical, and post-analytical, and also the feedback. So it's a teamwork. The clinician will choose a sample, the laboratory will do the process, and he communicate back to the patient and advise on appropriate antibiotic usage. What is antibiogram? Antibiogram is usually is generated statistic of antibiotics sensitivity pattern of the hospital, and each hospital should generate its own antibiogram based on the sensitivity pattern of the antibiotic testing capacity of the hospital. For example, now you are testing, you have so many different organisms, Escherichia coli, Klebsiella pneumonia, Streptococcus pneumoniae, Staphylococcus pneumoniae. For each patient, you isolated an organism, a bacterial agent, you test series of antibiotics. So in each antibiotics, you need to keep that record of that patient, the antibiotics you use. So at the end of the day, you will have a statistic of the common antibiotics that this organism is sensitive. For example, if I may be precise, let's say I have isolated Staphylococcus aureus in 100 patients. So out of this 100 patients, I tested 5 antibiotics. I have tested ciprofloxacin, amoxicillin, augmentin, ceftriaxone, and cefepime. So out of these antibiotics I have tested, what I found out that 70% of the isolate I have, out of this 100%, 70 of them are sensitive to ciprofloxacin. 50% of them are sensitive to, let's say, amoxicillin. So what it implies that in your antibiogram, you should recommend ciprofloxacin as the empiric treatment for any infection caused by Staphylococcus aureus. So as here now, ciprofloxacin in most of the antibiotic tested, we tested 165 patients with E. coli infection. So each patient has an isolate of E. coli. So this E. coli that we have tested, 58% of them are sensitive to ciprofloxacin, meaning that most of the E. coli we have isolated are sensitive to ciprofloxacin, implying that if now somebody come to the hospital and he has infection which is likely to be caused by E. coli, so empiric treatment should be guided by these statistics we have, meaning that I can start the patient on ciprofloxacin based on the evidence I have by the hospital antibiogram. Later on, if it's after, because I will still take sample to send for the laboratory to test to see if whether this organism, this E. coli, is still sensitive to ciprofloxacin. But if at the end of the day, now the report comes back to me telling me that this E. coli now you have bring to the lab is no longer sensitive to ciprofloxacin, a resistant to ciprofloxacin, but what we found out now, it is sensitive to ceftriaxone. So this one specifically, you change your antibiotic from ciprofloxacin to ceftriaxone. Otherwise, if it is sensitive to the ciprofloxacin, you maintain the drugs. Antibiogram identify important local resistance patterns. So if it has identified your important local resistance pattern, it guides you on how to take care of resistance and how to provide empiric treatment to all your patients. It increased recommended antibiotic prescribing for acute infections because it is like a guide to the general hospital practice on how to responsibly use antibiotics. So what are the key findings? What do we find? What do you do to ensure that your hospital is using, as I explained earlier, you have your data, you have a sample format on how you insert that data. Most of the data come from so culture, meaning that most of your data, most of the E. coli now are isolated, come from urine culture. So of this urine culture, how many of them were sensitive? Or let's say, how many of them were not from urine? Majority are from urine, but sometimes you can still have some from wound infection or sputum or CSF. So which one is the most? That is your target. The antibiogram will be most applicable when selecting antibiotics to treat so infection, because our data come most from urinary tract infection for E. coli. So this data, you can use it to treat any form of urinary tract infection that come to our hospital. So what it's trying to say is the positivity of the cultures, because most of the culture we have for urinary tract infection are E. coli. So directed therapy should go for treatment of E. coli, and the sensitivity pattern also should be directed to the sensitivity pattern of that E. coli we have in the antibiogram. So now, infection prevention and control. Infection prevention and control, as I mentioned earlier, is key to prevention of healthcare associated infection from patient to patient, patient to staff, and otherwise. So there's so many ways in which you can curtail infection prevention and control. You know, you have TB, HIV infection, surveillance, hepatitis B, community, and you have to engage community, because it's a kind of health education. You have to educate public on the importance of infection prevention and control. And it's a key to everybody when you come to the hospital, that patient as well as their relative should be educated on infection prevention and control. And it's more of discipline. It's more of how do we change attitude of our patient, attitude of our healthcare workers on the way they can prevent infection spreading in the hospital, to prevent healthcare associated infection. Now we want to establish infection prevention and control program. What does it entail? So for infection prevention control program, you have to have early detection of infection. That's the target. So any patient that come to the hospital, you have to have a way of how early can you say this is so infection that this patient is having. The earlier you know this infection, the better way in which you can prevention of spread of this infection from one patient to another, or from a healthcare worker to another patient, or from you as a healthcare worker getting it from the patient. And you need to have a close surveillance of multi-drug resistant organism. And based on my experience, most of the multi-drug resistant pathogen we have in hospital come from ICU. So you need to have an active surveillance system in ICU, as well as neonatal SCBUs, special baby care unit. You need to have an active. You don't need to wait until when maybe possibly you identify it. You go there, you take daily sample specimen from healthcare workers, the inanimate object, the utensil, the environment, so that to see if whether there's any organism that is thriving in that place. You need to have adequate rapid response to every possible transmission. For example, now you identify that 2 patients have methicillin-resistant staph aureus infection. What do? You need to respond immediately. You need to take measures so that sometimes you even have to close the ward or the ICU. You have to close it for a while to take all necessary measure to have a high level disinfection, so that there is no longer a thriving multi-drug resistant organism in that environment. Maximum collaboration and cooperation to ensure hand hygiene and audit is key. Hand hygiene, so many healthcare workers or so many patient-related and other, our hand and some part of our body, there are so many normal flora, but in some cases, this normal flora are drug resistant, and you can transmit infection from one patient to another. So hand hygiene practice is key to ensure there is no spread of healthcare associated infection in the hospital. Isolation measure and patient specific consultation. So if you identify that somebody is having an infection, multi-drug resistant, that can spread easily from one patient to another, you need to isolate that patient, like what we do in SARS. COVID-19 is a common example, the issue of isolation. The reason why patients are isolated of COVID, so that you cannot spread this infection within the hospital community, either from patient to doctors or from patient to another patient. So hospital-wide infrastructure is the hospital guidance for infection and antimicrobial formulary. So you need to have a kind of program that is working in terms of infrastructure, in terms of manpower, in terms of the design that can stop the spread of infection. So continuous communication within the healthcare system and unification of guidelines. So you have to be communicating your findings as far as healthcare associated infection, as far as antimicrobial resistance pattern, as far as your antibiogram to hospital community, to healthcare care workers, and also you need to have a guidelines that is acceptable for everybody in the hospital, so that you have a standard way of practice in the hospital to prevent all these problems you usually encounter. So what are the key facts on IPC and antimicrobial resistance? IPC, that is infection prevention and control, limits spread of infection and resistant bacteria in healthcare facilities, long-term care and congregate settings, in a community and in animal farming. So that is the target. How do you prevent this bacterial resistance spreading in our community, in our hospital, not only within the hospital premises or when you are taking care of your patient, as well as environment, as well as in animal farming? Because what it was statistically found out that there is so much abuse of antibiotics in animal farming. Infection prevention and control is one of the most cost-effective intervention against antimicrobial resistance. So now, treating, if I may give example now, it's better to prevent this antimicrobial resistance rather than to treat infection if patient is having the resistant pathogen. And you know, this resistant pathogen, you require higher drugs, and these higher drugs is costly. For example, if I may just give an example, for example, now you have a standard spectrum beta-lactamase producing bacteria you isolated from bloodstream infection. So if you have this organism and you need a higher drugs, you have to go to carbapenems. This carbapenem is quite expensive. Let's assume a vial of carbapenems is now 5,000 naira. So, and you need to give this dose 3 times per day. So meaning per day for 7 days. So you need 15,000 naira for a day times 7 days. So just if you calculate this amount of money to treat this single infection, so preventing it is highly cost effective, because when you prevent it, you also manage the cost of treating such infection. I think this is the end of my presentation. Thank you for listening.